Good morning and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name is Kevin Lockyer, I'm the Trust Chair. It's our usual practice to start our meetings with a staff or patient story, and we make no exception this morning. We're going to do that. I'm really pleased that we've got Olivia Jackson with us, who's going to share her experience of services and her journey into the role of an individual placement support employment specialist. So, Olivia, the floor is yours. We're keen to hear your story.
Hello, good morning, everyone. And yes, as Kevin just introduced me, my name's Olivia, and I currently work within the Trust as an IPS employment specialist. But my journey to that did start as a patient of this Trust. My first role as a peer support worker, given my lived experience as a service user. I actually found the IPS service, the employment service, so beneficial when my CPN referred me into it. And so I wish to illustrate that out of all the mental health services I have accessed, it was actually my experience with the IPS team that has been so wonderfully helpful to me and my long-term mental health. In fact, I believe it absolutely changed and possibly even saved my life. I've been supported twice by the IPS team, and the first time was in 2018. When completely out of the blue, I had a psychotic episode and I was admitted to PHC. After I was discharged, I entered a rather deep depression and I couldn't work for months. My natural healing centre that I had run for over 20 years, I was self-employed. I offered services like yoga therapy, aromatherapy, massage. I'm qualified hypnotherapist. And of course, that closed down. My long-time clients went elsewhere. And I was suddenly a single mum with 4 girls, a mortgage, and no income. So it was a difficult time, but my first employment specialist was absolutely amazing in supporting me with reopening and rebuilding the business. She helped me understand that it was actually better for me that I didn't have many clients now, as I could work into it more gently. She built my confidence up and eased me back into it. She encouraged that I'd be more likely to cope and succeed. She acquired me support with my benefits, an ESA claim and a PIP claim, which was absolutely invaluable. She supported me with all the remarketing of the business. She even taught me how to use a spreadsheet and how to do my own books. Because previously I'd afforded an accountant, but I couldn't do that now. So she actually taught me bookkeeping. Her ideas were so inspirational. She came up with the suggestion that I try taking my work into nursing homes as a mobile service, which I did, and that was a real success. She introduced me to some nursing homes. But then came the pandemic, and being a personal service, especially in nursing and residential homes, my business was the first to shut down and the last to reopen. And unfortunately, I hadn't been back in work long enough to qualify for any of the self-employment support grants. And so I was back at square one. My ES was in touch with me throughout the lockdown. She was fantastically positive and supportive. She would encourage me with statements like, "We've launched you before, Olivia, we can do it again." And so we did. We did it all again a second time. And then I was psychotic again. I was absolutely terrified. I was never going to be well, and that my children would be removed. And with the second business relaunch being a failure, another hospitalisation, and a diagnosis of bipolar disorder, again, another deep, long lasting depression and some heavy meds. After almost 25 years of running that successful business and raising my family, I was absolutely devastated and I felt like I'd lost everything. I absolutely didn't have the energy to relaunch a third time. So I made the sad decision to close the healing centre altogether. And in desperation, I took an income from a role in one of the nursing homes that I had been visiting when I'd been working for myself. This time as an employee, I was an activities coordinator that I was probably most likely rather overqualified for, but hoping that the nice, pleasant surroundings and performing some pleasant, gentle aromatherapy hand massages and nice treatments for the elderly residents. I did chair yoga and such. I thought it, without the stress of running my own business, it would actually be suitable, but actually it was even worse. It was even more stressful. In fact, it was awful. I hated every moment of it. I hardly got to do any of the nice activities I was supposed to be doing, because I was being always put onto the care side that I wasn't trained. Certainly wasn't hired for. I wasn't trained to do that. They were always so understaffed. I was just being told to swap onto the carer's role. It was so pressured, and I don't believe that the care that was being given was really to the standard that I would have liked. So I was a bit down again, but my mental healthness suggested IPS again. And I was so grateful for it because I didn't think I could have it twice. A new ES was assigned to me and recognised instantly, with all the lived experience I had and overcoming all these barriers to work, that I'd make a great peer support worker for the employment service. And so I applied and I successfully held the role for 18 months until the post of employment specialist became available. I applied to that, and again, I was successful. And thanks to LPFT provision of IPS and my ES's recognition, all that emotional support and guidance, particularly with my application and everything, I can really say how very proud I am to be working in this trust, giving back and helping people to overcome the similar issues, to work barriers that I had myself. I find the team so inspirational, the job so rewarding. I'm really proud of my progression, and my mental health is the best it has been in years. And I hope that's a real success story. I know you like to look at where things could be done better, or where things maybe went wrong. And the absolute answer to that would be, I wish I'd been offered it earlier, perhaps while I was in the hospital. I sometimes notice that we don't offer IPS perhaps so early, but that's maybe because our service users don't know that it's there, so they don't ask for it. I don't think that we should wait for them to ask for it. I think they should be told that the service is there as early as possible, because it gives so much hope.
Thank you very much. Sorry, Olivia. Thank you ever so much. Thank you for being so honest and open about your personal journey. And speaking personally, I'm really glad that you've got to where you've got to, even if it's not been the journey that you would have wanted to have, if you know what I mean. And you've obviously seen our board meetings before, so you know the kind of questions that colleagues are um, uh, uh, often motivated to ask, like how could things work better. So I will, if I can make my technology work, have a look at colleagues that would like to comment or ask you questions. So I've got Chris Wright first. Chris.
Thank you, Kevin. Hi, Olivia. I'm Chris Wright. I'm one of the non-executive directors. Thank you ever so much for telling us your story, which I thought was pretty inspirational and a great story of resilience. And you deserve huge credit, I think, for what you're achieving. My question is quite it's a there's a reason behind this question, but many IPS services are delivered by other organisations, not necessarily connected to an NHS trust. And I'm just interested in whether you think because IPS is delivered through LPFT, that gives it a kind of a better connectivity to the people it supports than an IPS service that might be delivered by a private company, for example.
Absolutely. As a service user, my experience would be that the dialogue between your clinician and the fact that they understand where we're coming from and that they are really able to take into account the barriers that mental health gives. I think the understanding, the compassion, and the obviously the rapport that is with the clinical team as well as the IPS team is invaluable.
That's really helpful. Thank you very much.
Thanks, Chris. We've got Chris Higgins next.
Morning, Olivia. My name's Chris Higgins. I'm Chief Transformation Officer at the Trust. Morning, and thank you for sharing your story. Really well, inspirational on a couple of levels, but from a personal level, I thought it was really good to hear. And also, as a board, we've been talking quite a lot recently about what more we can do to support people in the essentials in life, whether you've got meaningful occupation, a safe place to live, whether you've got a good support network in your home life and social life. And so it's really good to hear about that real life impact of that employment opportunities. I'm particularly interested in you talked about having an earlier offer in the pathway and in it for people, because part of the national programme is to expand IPS services, which is good news, but it's about how we're getting in and helping people access that service at the right time and possibly not. From what you said, I'm just wondering if you had any ideas around where we might be able to do that, or what would have worked for you in terms of that earlier support.
So absolutely, that would come into its own, particularly for retention. Now, I myself was self-employed, so that having that intervention and support much earlier on perhaps wouldn't have been so beneficial for me while I was still in hospital, but most certainly it would be for those that are employed and we're looking at job retention rather than finding a new job. And the earlier that communication starts, absolutely the better. Whereas while I was in hospital, I found just the little recovery college workshop posters on the notice board hopeful. Oh, I can attend that. So would seeing something that we can support you rebuild your life, or that this service was available, because that was just on the notice board for me to see on the ward. And maybe IPS perhaps going on towards and delivering a talk or just promoting it really much earlier. And I think I have noticed that when I've suggested at clinical team meetings, oh, would this person be suitable for IPS? You sometimes get met with, oh, no, they're not ready yet. And I don't think that's our call as the professionals to make. I think that it should be offered, and the service user themselves would say, oh, no, thank you, I'm not ready yet, because very often they're not. That's fine. They need to want to look for paid work or have support retaining their job. But you're absolutely right. It's such a holistic, life supporting thing. It's the one thing for me that really shouts our trust value of helping people live well in their communities. Is absolutely the way to do that, because it saved my home. It's me from losing my home. It gave me income. It gave me hope. It gave me self-worth. It got me back engaged with the community. I live in a small town in Lincolnshire where a lot of my customers were my friends as well, so I was quite well known, and I had a lot of like shame because I felt like I'd failed, but actually re-engaging with that community was really part of my recovery and part of the healing. So it's so far reaching. It has many more arms to it than just an income.
Yeah, well, thank you. That's really helpful and reassuring to hear that we're on the right track in our thinking. And with the expansion of IPS that's planned, I'll link up with Eve Baird, our Chief Operating Officer, and we'll think about how we can get that awareness out there and get the access better for people. So thank you, really helpful.
Thank you.
Thanks, Chris. Girish.
Yeah, good morning, everyone. Olivia, I'm Dr. Girish Kunigiri. I'm the Chief Medical Officer. I think Chris Higgins has already asked my question and you did answer, but just extending with regard to this drop-in services, as a clinician, I find that, when I discuss with my patients, they are not very sure whether they are ready, what it means, what it entitles, and so on, and what their commitment needs to be for this service. So my question was on the lines of drop-in service, what you mentioned, you talked about in the community, on the ward, whether it may be helpful to have something similar for patients in the community to drop in to IPS drop-in sessions. And also I was just thinking whether our service users get that option of like a taster session, with not any commitment, just to say, spend a couple of hours with the IPS staff and then see, is this the right thing or not? So I'm not sure whether that facility is currently available and whether you feel that may be a way forward in terms of encouraging more of our patients to get involved with the IPS. Thank you.
Yeah, absolutely. Anything that's promoting its awareness, people don't have to take it, but very often they don't know it's there, and if they do, they're more likely to take it up. And I think the use of peer support workers within IPS was so invaluable, because the feedback that I got was, oh, Olivia, you're so inspirational, or like, if you can do it, I can do it. And actually going in at a peer level was less daunting for people who might actually be quite overwhelmed by the thought of going back to work. But actually having peers really broke down a barrier and made the transition back to work more gentle.
Thank you. That's really helpful.
Thank you, Girish. Sarah.
Thank you. Hi, everybody. I'm Sarah Connery, Chief Executive here at the Trust. I just want to say a massive thank you, Olivia, for being so brave to share your story. And, the highs and the lows of your journey. Just so that the board are aware, I am the exec sponsor for the IPS service. I'm very proud to be so, because as I always say, they're quite a small.
I think I'm frozen.
Useful as well in terms of
we lost you. We lost you for a big chunk.
Sorry.
It's not just you, Olivia. We lost you for most of that, Sarah, I'm afraid.
Oh, did you not hear me? Sorry. Is it my issue? Yeah,
you've got a glitchy connection of some kind, so you froze for most of that.
Oh, I'm at HQ this morning. I'm at HQ. Can you hear me now?
Yeah, we can hear you now.
I'll try not to move or anything, but I'll just reiterate. So I'm Sarah Connery, Chief Executive here at the Trust, and I just wanted to thank Olivia for being so brave to share her story and, the highs and lows of your story. And I just wanted the board to be aware that I'm the IPS exec sponsor. I'm very, very proud to be so. And as I always say, it's a small team, but it's a mighty team. And as Olivia's expressed through her story, very creative and resourceful, to make sure that you're offering the best support that you can with the resources that you have. And just building on previous points, I'm absolutely delighted that one area that the Treasury are investing in is IPS services, and we are a growing team as well. But I think that is more incumbent on us then to make sure that we're shouting very loud about the service offer that is out there, to make sure that, you know, that extra resource is effectively used. So I think there's an action there for us, and you can pop me down for that, to make sure that, you know, we are using our comms internally to make sure that we are promoting the service as much as we possibly can. But just to say that we do get externally assessed around our model here at the Trust. It's called a fidelity model, and it's always rated really highly. So again, a big thanks for all that they do on that. But I'll shut up at that point. Thank you, Olivia.
Thanks, Sarah. Just as an aside, it would appear that we've got some technical issues at Trust headquarters. So participants in this morning's meeting that are based at Trust headquarters, it's probably as well if you keep your contributions as short as you can manage, without kind of doing yourself a disservice, because the connection does appear to be a little bit shonky, to use a technical term. Olivia, I think that's all of the questions and comments from colleagues. I just want to say a couple of things, if I can detain you for a little bit longer, and at the risk of repeating what other colleagues have said. You know, thank you very much for, as I said before, being so open and honest about your journey. Thank you for being so inspirational too. It just goes. It's a really powerful demonstration of the importance of personal resilience, you know, properly supported. So really glad that we've been able to help you get to the position that you're in, and really glad that you're now able to you know, benefit other patients and service users. And one thing that you said that I think is particularly powerful is the point about you know, the power of peer involvement in all of this, and your comment was, if you can do it, then so can I, and that's so true and so powerful. So thank you very much for that. You've also given us some things to think about in terms of how we best focus and improve access to the service as it expands and grows, with the extra investment that we will get. So all in all, Olivia, it's been a really helpful contribution to our meeting this morning, and thank you very much.
Thank you very much yourself,
all the best
for listening. Thank you.
Thank you. Let's move on then to the formal agenda of this morning's meeting, while people with spanners and hammers try to make sure that all of our tech works properly. Apologies for absence. We've got apologies from Di Bailey and Karen Scott. If there are any declarations of interest that are different to or in addition to those formally notified, then now's your time to shout. If there aren't any, we'll move on to the minutes of the Board of Directors meeting held on the 14th of August. If anybody's got any points of accuracy or matters arising on those minutes, can you please shout? Let me know in chat. If there aren't any, could colleagues please indicate whether or not they are content for me to sign the minutes to true record? Thank you very much, Tim. Very quick out of the blocks there. Thank you very much. We'll move on then to the schedule of actions. There are no outstanding actions. Completed actions are as indicated on the schedule. I'll take that as read if anybody's got any questions or comments on those. Pause to see if they have. There are none. Move on then to item 1.5, which remarks from the chair. I've just got a couple of things to say. The first is to note the fact that Girish Kunagiri, our Chief Medical Officer, this will be I think your final public board meeting. And as a result, I think it's only right and proper that I should put on record the board's sincere appreciation for your contributions to LPFT, and to wish you every good fortune in your new role, which we will be watching you from afar.
Thank you. I'll be only next door, so we will still be working as part of our cluster. Thank you so much for that.
Absolutely, and look forward to that very much.
Thank you.
So thank you for everything that you've done, Girish. And as I say, we wish you all the best.
Thank you.
And I look forward to welcoming our new Chief Medical Officer when all of that recruitment processes of that are complete. So I look forward to that. I also want to note, and Chief Executive says a little about this in her report too, about the move to the cluster ICB. As you noted, Girish, we will be continuing to work together in a wider system. So I'm personally, and on behalf of the board, look forward to working in that new cluster ICB arrangement. Look forward to working with the new chair and chief executive and building on the really positive progress that we've made over the last couple of years working with the Lincolnshire Integrated Care Board. And I'm sure that we will take that progress into our relationship with the new cluster. That's all in terms of comments from the chair. Happy to take any questions or comments on anything people think I've missed and should have commented on. If there aren't any, I will hand over to the Chief Executive, Sarah.
Thank you, Kevin. Morning, everybody. I'm Sarah Connery, Chief Executive here at the Trust, and I hope the IT keeps with me, but please do flag if I'm getting a bit glitchy and maybe I'll leave the meeting and rejoin. But I will keep brief, given that we are having a few IT issues here at Trust headquarters. I just want to start my report to say we are operating currently in a very pressured environment, particularly through our urgent care pathways. And I want to say a huge thank you to all the staff who are really pulling out the plugs to make sure that we're delivering safe quality services while we see quite a spike in our demand, as well as seeing quite significant complexity in the demand that we're seeing through our pathways. So a big thank you to staff. I do just want to highlight that we had, talking about clusters, we continue to work as a East Midlands Alliance as well for mental health and learning disability services. That's across the 6 main mental health and learning disability providers across the patch. And we had a joint board event on last Friday, which was really positive. We had a bit of a backward look in terms of everything that we've achieved over the past few years, as well as having some table work to discuss where we want to see ourselves over the next few years. So I'll be bringing that back to a future board in terms of the plan, not just for 25-26, but beyond. And it gave me an opportunity to present an update around our open dialogue pilot that I have spoken about at previous board events as well. So we do have a video for that, which I'll make sure is shared with board members who weren't able to attend. And for next year, we did talk about having the event slightly more northern, hopefully to increase attendance across all of our providers. Also, we've had a bit of a stock take in our mental health, dementia, learning disability and autism alliance, in line with our target operating model governance as well, just to say, what are those key issues around social determinants of mental well-being that we can work on together as a group of organisations, public sector organisations and beyond. So, completely ties in with what we were talking about with Olivia just then around employment, around housing, around social connection. So I'll be making sure that I bring the future plan back to the next board, if not the one after that, because we've got some work to do to consolidate our working within that alliance, given that we are, as a group of organisations, working with reduced capacity and in a significantly constrained financial operating environment. I won't cover all of the other areas, and you've already referenced the cluster changes, Kevin. And again, want to offer my thanks to Girish for all that he's done for not just for LPFT, but for the population of Lincolnshire as well. He will be greatly missed. We will have our new Chief Medical Officer hopefully joining us before the start of November. But we are going through the obviously rigorous checks and balances that we need to go through before they can start. I have included there a bit of update around Care Quality Commission activity here at the Trust, and we are obviously being as responsive as we can be to any data requests. We've recently had our CQC colleagues inspecting two of our rehab wards, and we haven't had any formal written feedback as yet, and we are still awaiting a formal publication of our final inspection report for our adult inpatient acute wards following the inspection back in June. I do just want to say I'm really proud that we've been reaccredited for our triangle of care, and she has retired now, but I just do want to put on record a massive thanks to Donna Bradford, who was instrumental in getting us where we needed to be. Not that we don't have more to do, it's a constant theme that comes up at the board around engaging with carers and families. But we'll continue to push forward with that. But really great news that we got that accreditation, which is no mean feat. I do just want to highlight around our plan to improve working lives for resident doctors. Obviously a really important and very valued part of our workforce. And nationally and locally, there is more to do to make sure that we're improving their experience. So we are working through a 10-point plan. It will be Girish leading with Amy as Chief People Officer, and handing over to the new Chief Medical Officer to make sure that we are attending to each of those action points, and that has been included in my report just so that you can see what we're being asked to do and that we need to do. And in fact, given the plan, we were already working on a lot of that anyway. Just to push our flu campaign, we're really keen to get our numbers up this year. We did really well in previous years, but it has been on a decline, not just here at LPFT, but nationally as well in terms of flu vaccination uptake. So a big plea to all of our board members to make sure that you get jabbed. And it's really easy to access on Sharon in terms of the various clinics where you can have that done. We are leading into awards season, so our LPFT Values Awards are open. Please to all colleagues and also members of the public. So you can nominate for our People's Award through our LPFT website. So please do, where you've seen that experience of great care and living by our LPFT values, to put in a nomination for people. We've got our Every Voice People Awards tomorrow, which we're really, really excited about. Our patient partners have done an absolute fantastic job in curating and leading those awards. So I'll update at my next board paper. And as you'll see from my background, it is Black History Month. So we are working as a system around a number of events. And again, I would urge members of the board to look at the calendar events and try and get engaged if possible. A really important month for us to celebrate Black heritage and culture. More important than ever, and we'll talk about our annual equality report later on in the agenda today. Our res data isn't quite where we would want it to be on a number of fronts, so we must continue to keep pushing to make sure the experience of our global majority staff is a positive one. So please do have a look for further information on that. I will stop there, Kevin, and I'm more than happy to take any comments or questions. Thank you.
Thanks very much, Cheryl. A quick one from me before I bring in other colleagues on the Alliance. And you and I have had a separate conversation about how to ensure that LPFT board is properly engaged beyond a kind of annual board event, joint board event, properly engaged in helping to develop the alliance strategy and so on. That's a piece of work that I think we need to pick up and pursue separately, because as you say, the alliance is important and we need to make sure that we've got proper engagement with it beyond a kind of set piece annual event, but that's something that we can progress. So I will move on then to questions and comments from colleagues. Tim.
Thank you, Kevin. So Tim Harry, non-exec director. Sarah, thanks as ever. Very rich report. Just one quick comment. I have my flu vaccination booked in for later on this afternoon. Really looking forward to it. Anyway, my question really is around the patient engagement portal, which again sounds sort of a very exciting development. I mean, I recognise this at an early stage and the scoping, etc. Do you have a sense, though, what sort of timescale this is likely to develop over and become operational?
I could try and do it justice, Tim, but I wouldn't do it as well as Mark. So if I can ask Mr. Platts to come in at this stage. But yes, we are really excited about it and completely in line with the 10-year plan.
Yeah.
Yeah, good morning, everyone. So I'm Mark Platts. I'm the Chief Finance Officer, but also the Executive Lead for our digital and data services as well. So thanks, Tim, for the question. It's it's an interesting one because across the NHS, there's been different approaches to implementing the patient engagement portal. My big focus is we do it right once. And as a result of that, we're really carefully going through the specification at the minute so that when we go to market, we've got a clearly defined product that we can work with and we can really understand and make work. Interestingly enough, I was at a national Chief Finance Officer event yesterday, and there was a lot of talk about nationally driven apps that we can bring into our patient engagement portal to help support letters and other digital improvements moving forward as well. So I don't think it's going to stop. I don't think it will be an implementation program of 12, 18 months and then we'll stop. It's going to be ever evolving as different services and add-ons and kind of improvements come online, really. But certainly 12 months time, we'll have a much better process and system that we have now, with the NHS app being the front door into information. But I don't want it to stop. I want to keep reviving it and improving access. Hope that helps answer the question, Tim.
Yeah, no, thanks, Mark.
Thanks, Tim. Chris Wright.
Thank you, Kevin. Thanks, Sarah. Lots of activity as always. This is a very specific question. As many of us participated, I was going to say benefited, but I think participated is a better word, in Come Dine With Me. And I think we all came away feeling pretty disappointed with the quality of the dining experience and the food that was on offer in our inpatient ward. So it's really encouraging to see that we've changed our supplier. I guess the question is, what confidence can we have that the new supplier will provide better quality, more diverse food choices? And then secondly, where are they based?
I can answer one of those bits of the question, but not the second one, I'm afraid, Chris. But so in terms of the ongoing quality assurance, we do have our place assessments that we do that does have service user input to it. And as part of the learning from the Come Dine With Me, we do come back to quality of food through our Every Voice group and our mini Every Voice groups at the local level. I'd be really interested for us all to redo Come Dine With Me on the back of having the new supplier, maybe give it a few months to bed down. But if members of the board would be up for that, then I think that would be a good way to circle back and go, actually, this is what we learned. Have we actually improved and moved forward? So if people would be happy with,
yes, absolutely,
time to come back to it.
Absolutely, Sarah. It's definitely worth doing.
But in terms of location, again, I will have to defer to my esteemed colleague, Mr. Platts, to come in on that one, if that's okay.
Morning, Chris. Great question. I'm going to have to admit, I'm going to have to take the location away, but from conversations, I believe we've got regional bases across it. It's a much bigger company that had a lot of experience working with schools and other kind of healthcare institutions as well. So a lot more broader experience. One thing I did want to talk about, as part of the implementation, our estates and facilities team have actually gone out to a number of different sites. So we've had a site in Lincoln, Boston, and I think we're going into Grantham soon with taster menus. So myself and Sharon Harvey, Chief Nurse Officer, went over for the tasting session. And actually, I was quite impressed, even down to some of the thinking of the organisation around the recycling of the containers that the food came in, how it was served and how it was cooked. So it felt a much more considered offer, and we'll do that. But as Sarah said, we can't be going back out and seeing it when it's implemented. But I will come back on the locations by the end of the meeting.
Thank you very much. Cheers.
Thanks, Chris. Ian.
Yeah, morning. Thanks, Chair, and thanks for the report, Sarah. Mine's a very, very straightforward one. The CQC report, you say we're awaiting the response, Sarah. I just wondered if we've got any indication of when that might land, given that we're talking about a report that, you know, the spade work started in June.
No, I'm afraid not. We did have an engagement meeting lined up for this month where we would have been able to have that conversation, but given the CQC are undergoing a current restructure, they have moved to more sort of area relationships and sectors, but now they're going back to sector specific. So there will be a mental health lead as opposed to a sort of regional lead, if that makes sense. So there is obviously a lot going on in that space in terms of changes of staff, but I think it's fair to say that the information system that they're using probably needs a little bit of work as well. So it's not just dealing with changes in leadership, but there is also work to do, I think, in terms of their reporting system as well. And that's something that's, you know, been talked about in terms of the national review of oversight and regulation, led by Penny Dash. So sorry, that was a bit of a long-winded way to say no, I'm afraid I don't know, but hopefully sometime soon. But we will keep engaging with our local relationship managers to try and keep you updated as much as we possibly can.
Thanks.
Thanks, Ian. Don't see any other questions or comments. So thank you very much, Sarah, for a characteristically full and helpful report. Thank you very much.
Thank you, Chair.
We will move on then to item 4.1, which is the highlights and exception report from an extraordinary meeting of the People Committee. Tim.
Yeah, thanks again, Kevin. So Tim Harry, Non-Exec Director and Chair of the People Committee. So you have a report from an extraordinary meeting of the People Committee, which was primarily to review and recommend various key and mandatory reports to come forward to this board meeting. The first of these is the annual Equality, Diversity and Inclusion report. This is elsewhere on the agenda, so I'll obviously leave Amy Beaton to cover the detail. But just to say, this is the first time that a number of different EDI reports have been consolidated into one. And I think we found as a committee that this was very helpful and provided more insights than before. The bottom line is progress has been made in many areas, but there are still some issues requiring continued attention. The second is around the medical workforce plan, and Girish, as Chief Medical Officer, presented a paper. It highlighted a number of improvements around recruitment and reduction in agency costs and alignment with the Trust strategy. We also had a thorough debate around the future medical workforce plan. And this was in light of recent discussions at board and the ongoing transformation of the forum and developments at the divisional level. So in particular, we were thinking around the target operating model, and the care pathways. So I think in conclusion, we recognise that good progress has been made in this area, but that a revised proposal for future workforce plans will need to come to the board at a future date when matters are clearer, and also with greater alignment with divisional workforce plans, which really need to reflect the greater multi-professional approach that is part of our way forward. The final one, which is also on the agenda, is around the annual fire safety report. We got assurance around where matters currently are, in that we're not 100% compliant, but really good progress has been made, and there are a clear set of actions to bridge the gap. And again, more detail will follow when the item comes up on the agenda. And I think, Kevin, that was probably it.
Thanks, Tim. See if we've got any questions or comments from colleagues. Sorry, bear with me while I wrestle with IT for a second. No, don't see any. Thank you very much, Tim. We'll move on then to the next item, item 4.2. Amy, this is you, the annual equality report.
Thank you, Kevin. Yeah, my name is Amy Beaton. I'm Chief People Officer here at the Trust, and really pleased to be introducing this item today. So last year, I recommended to board that we would combine our EDI reporting into one report, as Tim has just said. We were fulfilling our statutory and mandated requirements, but not always supporting the organisation to gain insight that enabled focus and improvement in the way that we were reporting in a number of separate reports that would come to a number of different meetings. So we also heard it was slightly confusing, and we also heard that there was duplication as well, in terms of often the actions would be the same across a number of protected characteristics. So it was quite repetitive in the reports. So by bringing it all into one document, so this is the first time we've done this, we've got eyes on the data sources at the same time, which means we're triangulating that equality, diversity and inclusion data before then bringing in other quantitative and qualitative data. So this is our intended approach going forward. That said, it has been a step too far for us this year to include the equality delivery system into this annual equality report. We've had living within our means, and the amount of work required into EDS has just made it it has made it impossible for us to do this year, but it is our intention to do that for following years. In addition, I hope that board can see the progress made in the presentation of this data. So as Chief People Officer, I feel we've made huge strides in this area, and I am really proud of what the team has achieved. You'll see we've adopted a format that we hope to close the feedback loop from previous years, which I don't think we always did. And we've hoped that this is more easy to follow. So you can see we've got 4 objectives, and we describe what we did, whether it made a difference by using the new data under each of those protected characteristics. So what did we say we would do? What did we do? And has it made a difference? We've also put more of the mandated reporting into the appendices with key messaging in the body of the report. And this is because we also, whilst want to and need to fulfil our statutory mandated obligations, we want to use the report beyond that. We want to see it as an attraction and marketing tool and supporting our retention. So easily articulating to our staff what we're doing around inclusive culture, which is one of our strategic ambitions. And these changes, we believe, has made the document easier to read, easier to identify key messages and actions being taken, and so is more likely to be picked up and read and retained. That said, we are really welcoming board members' input for any further improvement on the presentation or this combined approach. Just to pull out a few key things around data. So the covering paper highlights and summarises the results, pulling out where we've done well, not so well in seeing widening of inequality gaps, and our focus in addressing these inequalities. So our approach with our EDI work is to focus on a fewer number of priorities, hence you'll see that in the report. That we believe will have a big impact. And whilst I do say a few, some of them involve really extensive work. So we did a piece of work where we mapped the inequalities across all protected characteristics and chose to focus on those consistently coming up. Although where we have needed to tailor, we have done so. So going forward, we will continue to retain the 4 headings of those objectives for next year, because we believe that collective and focused attention in fewer areas will impact and help shift the cultural change needed. So just to say, in People Committee, as Tim has highlighted, we did go through the key messages from the data, celebrating some of the positives we'd seen, shift, and they are highlighted in that covering paper. We also spent some time discussing where improvement was needed, our progress on some of those agendas, and what more was planned as a result of the insight and engagement. And I think the one area we really focused on in that committee was our staff safety agenda. It's an area that's highlighted in our National Staff Survey results, in this EDI data. It's one of our quality priorities, and it's also a ministerial driven agenda through NHS Staff Council recommendations. And the paper highlights some of the challenges we've faced around patient to staff harm, and some of the delays that have been caused, some in part by living within our means and support services redesigning, mobilising some of those interventions we know are needed. But some delays caused because it is a really complex agenda, and we need to have clarity in place around processes, support offers, so that we improve the position rather than make it worse. So we're not avoiding these conversations, we're still driving them forward, knowing that it's important to our staff and that their safety has a strong link to the quality of care they provide. So to finish, I would ask board, can they approve on the recommendation of People Committee for the uploading of our annual equality report to our website and to submit into NHS England. And we would really welcome any comments around the approach and presentation. I'd also like to say a huge thank you, if I can, to our equality, diversity and inclusion and organisational development team members that have made this possible in getting this vision a reality, and to our staff networks for aligning their objectives to improving the inequalities shown in our data. The work they have achieved and continue to do so is really valued. So thank you.
Thanks very much, Amy. For my part, really like the format of the report, and as you say, it closes the loop rather better than we have in the past. Presentations, I think, first class. It's got the right balance between kind of detail and impact. So, top marks for that. It's really good. Thank you very much. Let's see if we've got any questions or comments from colleagues. I can't see any. So, can colleagues please indicate whether or not they are happy to approve submission of the report as presented. Fabulous. Thank you very much, Amy, and please pass on the board's thanks to everyone that's worked on this and got it to, to this place. It's excellent.
Thank you.
So let's move on then to item 4.3. Girish, this is your swan song, I think. Just the medical staff revalidation and statement of compliance report.
Thank you, Chair. Good morning, everyone. I'm Dr. Girish Kunigiri. I'm the Chief Medical Officer, and today I'll be presenting with regards to the paper on medical staff revalidation. The purpose of the report is to provide assurance to the board that LPFT is compliant with the statutory requirements in relation to maintaining medical staff appraisal and revalidation. Those who are not very familiar with that, all the doctors have to go through revalidation cycle, which is once every 5 years, to indicate that they are fit to continue their practice. And for the purpose of revalidation, every doctor is expected to go through, certain measures. Some of them include participation in annual appraisals, having a multi-source feedback, review of all the complaints and the serious incidents they may be involved in, and also if there are any issues related to professional standards, and also involving in audit cycle and quality improvement. One thing which is again important to note is it is not just related to the organization, but all the activities which are done outside the organization related to professional activities should be included into the appraisal as well as the revalidation process. So that's why getting evidence from areas other than LPFT, if they have been involved in, is very important in terms of appraisal and revalidation. So in LPFT, we have a very thorough process, and our compliance has always been really good. And we have digitalized most of our process, which definitely helps in terms of monitoring. So in terms of the figures, as you would have seen in the report, so we had 86 doctors during that period, 24-25, of which 71 doctors have completed their appraisal. Out of the remaining 15, there were 12 who were new starters. We know that in the last 18 months or so, we had good number of recruitment, which was definitely positive. So they have not finished their first 1 year yet to complete their appraisal. And there were 3 where the revalidation and the appraisal was not done. And the reason was one of them was on long-term sick, and the other one each was on paternity and maternity leave. So as per the guidance, there is a clause to exempt these people from appraisal for that period. So in terms of the revalidation, we have a group which is called as the Responsible Officer Advisors Group, which is chaired by the Deputy Medical Director and is attended by all the clinical directors as well as myself and the HR. So we had reviewed 29 requests with regard to revalidation from our doctors, out of which 5 had to be deferred for 6 months so that we can collect robust evidence related to all the appraisals as well as the multi-source feedback. And 2 were deferred because of ongoing investigations, both of whom have now left the organizations. I'm pleased that in LPFT, we don't have any issues with doctors' engagement with appraisal and revalidation, and we are generally very compliant. So in conclusion, the board needs to note the progress and the compliance with the statutory requirement. And if the board is satisfied, to sign the statement of compliance, which is attached as an appendix, which is a very detailed report, which we have to annually submit to the GMC every year. And this needs to be signed by the chair and CEO or CEO if satisfied. 2 things to mention with regard to this statement of compliance. The first one is it is required that at least every 5 years we have a peer review appraisal and revalidation process, so which we are looking into it. And the second one is having adequate number of trained case investigations and case managers. So in our organization, we have 15 trained case investigators following the sessions we have put in our organization. At the moment, I'm the only trained case manager, and we have set up some training program for some of the other staff to become the case managers going in future. So I'm happy to take any questions, Chair. Thank you.
Thank you very much, Girish. Got a question from Tim.
Yeah, thanks, Kevin. So Tim Harry, non-exec director. Girish, thanks very much. I mean, that's a very thorough report, and there's lots of metrics in there, so we get a quantitative feel for what's been happening. There's material around the qualitative aspects, which is obviously equally important. My one question really is around, so the metrics are around obviously individuals and compliance, etc. Is there a process where themes are picked up from across the various sort of appraisals and sort of issues? How does that actually happen?
Yeah, thank you. That's a good question. So we have two ways of collecting that kind of feedback. So one is in terms of having quarterly appraisers meeting, where we have about 7 or 8 appraisers. So we meet once every quarterly and we discuss about what the key themes are coming, which then we use in terms of our annual training and retraining on appraisal to all our doctors. And the second thing is we do have the responsible officers advisory group, where all the clinical directors, myself, meet with the HR, and we go through all the appraisals we get, and we try to pull out what the key issues which are coming in addition to individual issues, which then we feed back in terms of our training program. Thank you.
Thanks, Girish.
Thank you, Tim. Ian.
Thanks, Kevin. Thanks, Girish, for the report. Mine, again, I think is a very straightforward one, Girish. You make reference in the report to locums. And unfortunately, the bit that caught my eye was on the risks and issues. So my simple question was, does the report, which is a slightly technical report for me, but what I'm searching for is, in terms of quality of the locums, have we got any concerns there?
Yeah, thank you. So in terms of the responsible officer status, I am responsible only for the doctors who are employed by LPFT. If we appoint the agency locum, then the responsible officer for them will be the RO of the agency. Every agency needs to have an RO. So it is the responsibility of that RO to collect all the evidence for each of the locum doctors before they certify that they are fit for revalidation. So one of the things what happens in our practice, which we have seen a couple of times even in LPFT, is that when the locum joins, we identify some issues with the locum, and we then raise it to the responsible officer of the agency, and then the locum chooses to leave. So at that point of time, we may not know exactly what the outcome of the concerns what we have raised, and if they have not been adequately dealt with, then there may be a potential chance that the locum may continue to have the same issue in other organization as well. So that is why it's the risk not just to our organization, but it is a risk to all organizations who appoint locum. So that's why we need to make sure that when any request we make for locum, we have our internal process to make sure that the locum has not just the revalidation status, but also make sure that there are no concerns and complaints from other organizations as well. Thank you.
Thanks.
Thanks, Ian. Now, Girish, the board needs to formally approve the appendix, doesn't it, for submission to NHS England? So I'd be grateful if colleagues could indicate whether or not they are content so to approve. Fabulous. That's good. Thank you very much. Thank you, Girish, for that very helpful and detailed report. Thanks very much.
Thank you.
And we will move on then to item 5.1 on the agenda, which is a highlight and exception report from the Performance Committee, for which I think, Sarah Whiteman, you're undertaking a guest appearance.
I am standing in for Professor Di Bailey. Thank you. I'm Sarah Whiteman, one of the non-exec directors. Good morning. The Performance Committee met on the 23rd of September, and we received the first annual report from the Performance Delivery Oversight Group, known as PDOG. 4 main areas that we heard about: reporting in line with national guidelines, the introduction of care groups within the trust, care planning and risk assessment, and the implementation of the target operating model. Within the integrated performance report, which we'll hear more about later, we noted the increase in the number of complaints and out of area placements. We noticed that their work in progress, particularly with respect to measurements indicating how safe people feel in our care. So this is something that's definitely evolving. We talked about the balanced scorecard, and the balanced scorecard is more of a strategic tool that feeds into the integrated performance report to keep more aligned with our strategic priorities. And then we talked about the national oversight framework, which is how we perform with other people, essentially. Thank you. Happy to take any questions.
Thank you, Sarah. It's very helpful. Any comments or questions from colleagues? No, I don't see any. Thank you very much, Sarah, for that. And we'll move on then to the integrated performance report. Mark.
Hi everyone. So thanks, Kevin. As usual, I'll do a kind of handover to Eve, and then I'll come back to close the report if that's okay. So just going through this month's integrated performance report. So I just want to start with the first page of the report for any members of the public that are watching, just to give some assurance around the performance assurance process that we have within the organisation, because the integrated performance report in terms of the data is fairly high level to support board level strategic discussions, but it's important that we're all aware that there is much more level of detail of kind of assessment, scrutiny and challenge held at a number of different levels of steering groups and divisional meetings as well. So important to note that one out. In terms of the performance headlines for this month, I'm going to open up by talking about our workforce. So we are currently reporting 94 whole-time equivalents below plan. What we have done over the recent months is done a full investigation around the impact of those vacancies and how is that impacting on patient care. And whilst there are some areas that we will be working on, and there are some areas of significant concern and focus that I'll come on to shortly, we have assessed the impact on patient care as being manageable, and it's an area that we can work with staff to continue that service provision. So whilst we're below plan in terms of the numbers of people in the organisation, we're continuing to provide the best care that we can. And agency and bank staff expenditure is also below plan, and some of that is because of some of the areas of recruitment where we've been focusing on supporting our inpatient services to try and stabilise the workforce as much as we can. From a quality perspective, and Sarah just mentioned this as well, for transparency, we have received an increase in formal complaints. Now, this is due to local resolution practices that are not necessarily fully embedded, and we're working close with patients as much as possible to make sure that we can shape and develop our services at the point of delivery rather than having to wait for a complaint to come in to get things right at that point. So we really want to get that flow of innovation and working with patients right on that one. So in terms of areas that are going well, I'm really pleased to say we've got some strong partnership working. So we're working with United Lincolnshire Teaching Hospitals and really making the best use of their estate in terms of their community diagnostic centre in Lincoln, which has opened in recent months. So working with the group with that, we're now able to provide diagnostic services for our eating disorders services, and we're really hoping that with a successful pilot and review of that, we can roll that out across the other community diagnostic centres across the county. So that's a really important pilot that we're looking to develop with that as well. And also, this is a really positive one, our memory assessment clinic. So we're now looking to hold that at the centres as well, because they're open 7 days a week. So that's really going to help improve access and ability for our patients to get care as they can in the community. So two really important areas of development there. From a children and young people perspective, so we are above plan for the number of children accessing services, and that has been an area that we have had challenges with, but some really innovative use of the digital game-based therapy that I know we've presented in board recently. We're now really seeing the benefit of that coming online. And we also continue to work with Lincolnshire County Council to improve our reporting of activity that we are undertaking as well. So some good areas of refinement. However, we do have some areas of current challenges. So the report touches on the criminal justice and forensics services. So very, very bespoke niche service, and as a result, sort of losing 1 or 2 members of staff can have a significant impact. So we are seeing a bit of impact on that, but we have got full recruitment campaigns underway, and we're mitigating where we can possibly to move that forward. So again, where we need to recruit, we're really focusing hard to make sure that we can support the development of services around that one. Again, Sarah mentioned out of area placements. So whilst the activity data that we're looking at in the integrated performance reports does remain low, and that is positive from that, we really need to be aware that fluctuations in service demand, we've got to support our patients in the best way that we can. So that will continue to fluctuate in future months. Female psychiatric intensive care unit beds are a pressure point that we're working with our partners to try and understand and limit that where we can. And to help increase the flow on the patient pathway, we're also working with partners to open Ashley House as a step down facility to improve patient flow. That's opening this month. So again, we're hoping to see some real positive impacts of that opening as well. A previous ask of the report was to look at how we benchmark from our workforce data. So we've got a full section in there looking at our regional peers, particularly relevant now we're moving into the integrated commissioning board clusters. So from a vacancy rate percentage, we have seen an increase in that. So we have reported a 10.78% vacancy rate. That was expected, because as we continue with our Living Within Our Means programme, we start to look at some restructuring of our services within our corporate support functions. That was expected to kind of increase as we were going through that, but it's an important process that we're going through, so we'll continue to manage the impact on our services as we move forward. Sickness absence, 4.86%, so this is below regional average. So there is a bit of variation across other providers that you can see within the report, but we are below the regional average, so positive on that one. And likewise for our turnover at 8.27%. So fairly static and controlled from a workforce metrics perspective for the organisation overall. So if it's okay, Eve, I'm just going to hand over to yourself to talk through the more performance angle of the report, and then I'll come back to close if that's okay.
Thanks, Mark.
Thank you. Good morning, Eve Baird, Chief Operating Officer. So picking up where Mark left off, looking at some of the very specific performance targets in the IPR, we've got lots of areas where we're performing at target or above target, including our targets for Lincolnshire talking therapies. As Mark referenced, our children and young people's access rate, which is really positive and something we've been working really hard on, but also our follow-ups of adults within 72 hours once they're discharged from our wards. We're doing well with that, and that's a really important metric because that period of time as someone is discharged from a ward can be quite a vulnerable time. So making sure that we are making contact, finding out how things are going and putting in support is really important. There is work to do with some of those metrics, and you'll see that on the IPR. So when it comes to physical health checks for people with a serious mental illness, we're not where we want to be on that target. That is a system target, and there's work for us to do with our colleagues in primary care to make sure that we improve that position as the year goes on. And also there's work for us to do on our IPS access target. So that's the service that we heard about first thing this morning. And we're not where we want to be in terms of number of people being able to access that. But that's because we've currently got a recruitment campaign live with 4 more staff going on board to allow us to expand that offer. And that's following additional investment nationally in IPS services. So we are on track to see that increased access once those posts are recruited to. In terms of access and waiting times, there's some really good information in the report around the social return on investment of our community assets that were developed as part of our community mental health transformation scheme. And it's really nice to be able to see the social return on investment articulated so clearly. We do report on 4-week waits as they are nationally reported, though those metrics are still in development, and there is work for us to do to improve our performance on those metrics. But alongside those nationally reported metrics and the way that data is captured, we are locally reporting on waits from a patient perspective. So what do our waits look like from a patient perspective in terms of from the moment they seek help to the moment they get contact and start to receive support? And actually what we're seeing is consistently better performance in that local data than we are in the way the national data's captured at the moment. So there's work for us to do on that. We're seeing really positive performance in terms of our crisis response for people that are recorded as very urgent. However, there is work for us to do for those individuals who are recorded as having an urgent need for crisis. And some of that is work for us to do with our commissioners for our children and young people's service, as we're commissioned slightly different to the national expectations. There's also work for us to do in terms of how we record people who come and access our other urgent care services that aren't part of our crisis team. So we are actively working on that. And finally from me, just in terms of patient experience and outcomes, really positive to see that 91% of patients rated their experience with us as very good or good, and 86.2% felt involved in care decisions. I would like to see that number increase. I hope we can get to a point where everyone that comes into contact with us feels involved in their care decisions. Our services are continuing to embed the use and recording of clinical and patient-reported outcome measures. We've been using those measures for individual patients. What we've not always had the ability to do is aggregate the measures up and report on them in a way that helps us monitor the impact of specific pathways or specific interventions. And through some really positive work by the digital and data team across with clinical services, we're now in a position where we're able to start to monitor that routinely, really, as part of our routine business. So that feels really positive. And I believe I'm handing back to Mark.
I think you are, Eve.
Thanks, Eve. Thanks for that. So an important focus of the IPR is to look at our operations as an organisation, but actually it's underpinned as well by our financial sustainability. So I wanted to make sure the report focuses on our performance, but also close noting the reporting of our trust financial position. So as has been noted in the report previously, we have planned a deficit as an organisation for this financial year of 3.72 million. That was a strategic decision to allow us some time to look at our rebuilding programme, and that's with the Living Within Our Means programme that's going to help us make sure that in future years we do remain operating in a financial balance, which is the national mandate, really. So important to note that from a system perspective for this year. In terms of our year to date, We are broadly hitting our financial plan at month 4 around that. So we are reporting the £1.6 million deficit that we have in there. So we were slightly off at month 4, but again, that was expected with some timing of some payments that have come through. However, I'm confident we're going to recover that and look positive to meet our plan for the year as we go through the Living Within Our Means programme as well. So really good tight control there from our clinical colleagues. So thank you for that. Agency expenditure. This is a real positive. We're seeing a significant reduction in our agency expenditure at the minute, and that's as a result of some really strong recruitment, particularly around our medical consultant roles. So many thanks for that. That's not only allowing us to spend less on agency premiums, but helping us to bring stability back into our services, which is really important. And our cash and capital expenditure, again, unfortunately, year to date are slightly lower than planned, but we will be forecasting that to remain on track by the end of the year, particularly around our capital expenditure, because the majority of our spend is linked to our new eradication of dormitory scheme in Norton Lee, which I'm really excited. We're getting closer and closer to opening, so that will be delivered on time and on budget. So another good example of the use of our resources. So happy to take any questions, Kevin, on any aspect of the report.
Thank you, Mark. Thank you very much, Eve. Too, I think the IPR generally has matured really nicely into a report that covers the territory really well and gives the board some really good insights into performance and the context of performance in the trust. So really grateful for that. Really grateful too, Mark, for the way that you and Eve have talked us through it. So thank you very much for that. I don't see any questions or comments from quite. Yes, I do. Sarah.
Yeah, just a quick one. I want to reiterate the thanks to Mark and the team. We've talked a long time, haven't we, about wanting to have more of a feel for the outcomes that we're achieving for patients. So just even having some statistical process control charts on how we're capturing the outcomes. And obviously the next step is talking about how we're improving them at a patient and population level. So, it's really heartwarming that we're getting there step by step. So, but appreciate that is very challenging. So a big thank you to your team, Mark, and a big thank you to Eve's team for actually pushing forward on making sure those outcomes are captured. So thank you.
Thanks, Sarah. Tim.
Yeah, thanks, Kevin. So Tim Harry, non-exec director. Mark, quick question on the capital expenditure. I kind of lost track a little bit in terms of where we are with Norton Lee and the construction. I assume we're primarily now working on the internals of the building rather than externals. And I ask that obviously because we're going into the sort of winter piece where, weather can have an impact. But if it's internal, then the confidence levels must be higher.
Yeah, we're fully on track, Tim, for handover. So we'll be in there by the end of the year. So really positive to see it. I was on site a couple of weeks ago and it's unrecognisable. The pace of change is phenomenal.
Brilliant. Thank you.
Sorry, slight technical glitch there. Thank you very much, Tim. Personally, really looking forward to visiting Norton Lee again, Mark, and seeing the progress, which I'm sure is phenomenal, even since the last time I was there in the summer. So I look forward to that. Excellent. Thank you very much, Mark. Thanks again to Eve. We'll stay with you, Eve, then for item 5.3.
Thank you, Kevin. I won't reintroduce myself. So I'm bringing a paper today that's been through your best use of resources committee. I'm not planning to read through the entire paper. It's a really detailed paper, but I do want to give a bit of background. So as the board are aware, in April 2020, Manthorpe Ward, which was an 18-bedded assessment and treatment ward for older adults with dementia, was temporarily closed as part of our response to COVID-19. And at that time, staff from the ward were redeployed to another dementia ward in the trust, and also to enhance our community services offer. During this time, LPFT had been providing a home treatment service for older adults with mental health needs, which was demonstrating really positive outcomes for patients and their families. And we had a lot of feedback at that time that was highlighting the inequality in provision between having that enhanced treatment support for older adults with mental health needs, but not having it for older adults with dementia. So in November 2020, as the pandemic continued and we weren't able to reopen Manthorpe at that point, we started to pilot a dementia home treatment service. Since that time, we've continued to monitor data and, most importantly, patient care and family experience to assess the impact of the change. And in April 2023, with support from the Integrated Care Board and the Health Scrutiny Oversight Committee, the pilot was extended for a further 12 months, with the aim being that we further developed the service and completed a full evaluation of the approach. And at that time, we also engaged with the East Midlands Clinical Senate and asked them to undertake a review of the potential future model of care and provide some external clinical advice and feedback on the proposed pathways. So following the success of the extended pilot, which has included supporting more individuals at home, and I think it's notable that only 13% of the 1,029 patients referred to the dementia home treatment team at the time of writing the report went on to require an admission. So what that tells us is that 87% of people were successfully supported and remained at home in an environment that was familiar to them. And we know that's really important. It's important for all our patients, but particularly for our patients with dementia. The East Midlands Clinical Senate supported the Trust proposal and acknowledged its alignment with national priorities. The paper does provide a lot of detail regarding the dementia home treatment service, the findings from the Clinical Senate review, the internal evaluation and outcomes of the consultations that have been undertaken in relation to the proposal to permanently close Manthorpe Ward and substantively fund the dementia home treatment service. So following all of the extensive engagement, we feel operationally confident to recommend the permanent closure of Manthorpe Ward. We have still got capacity in our older adult dementia inpatient services. We haven't had to send people to services outside of Lincolnshire in the entirety of the time that Manthorpe Ward has been closed, and we are seeing an improvement in patient outcomes. The Best Use of Resources Committee reviewed the paper in detail and have recommended the board approve proceeding with the permanent closure of Manthorpe Ward and continued investment in the dementia home treatment service on a substantive basis. And the paper's also been to the Integrated Care Board executive team, where it's received support and no concerns raised.
Thanks, Eve. A really excellent report. It seems to me this is, as Chris Wright said in chat, clearly in line with the NHS 10-year plan, clearly in line with the trust strategy, what we're doing on target operating model and all the rest of it, and and where we want to be as an organisation in the future. So I very strongly support where we are. Questions from colleagues. Tim.
Yeah, thanks. Eve, I mean, this is, a fantastic piece of work, and I think it's a real model around change and transformation, whether how you handled the engagement process, keeping everybody sort of involved, etc. I just wondered though, despite me saying all that, is there anything, reflecting back, is there anything that you would have done differently or we could have done differently?
I think reflecting back, the length of time it's taken for us to move from pilot to proposing the decision to make the change substantively has been a long time. And And while that hasn't impacted on patient care at all, what I think it has impacted on is perhaps some of our staff who were redeployed originally from Manthorpe, and so I think one of my areas of learning is we could have moved to the formal evaluation quicker. And that's something I'd be looking at in any future developments, is building in that formal evaluation at an earlier stage, because then we'd have been in a stronger position to make a recommendation earlier on.
Yeah, no, thanks. And that's partly why I asked the question, really, around, sort of thinking about the changes and transformation that we're inevitably going to do, what we would do differently. But thank you.
Thanks, Tim. So I think the question is, Eve, whether or not the board approves the recommendations in the report. So can I ask for colleagues, please, to indicate whether or not they do? And just to reiterate, fantastic piece of work, and thank you very much, Eve and colleagues, for getting us to this stage.
Thank you.
Great stuff. Thank you. Let's move on then, because we're in the home straight almost. So I'm going to press on until we've finished. Amy, I think item 7.1 is next, the annual fire safety report.
Thank you, Kevin. Yes. So here today also for approval, please, from the board. So prior to here, the report has gone through our estates and facilities governance and our health and safety group, and through to people committee. So we've had the scrutiny in those governance for expert input has also been provided by our fire safety manager, health and safety manager, and the estates and facilities team, as well as external contractors. So the report incorporates findings from the authorising engineer, the audit and statutory inspections by Lincolnshire Fire and Rescue Service. A smoking related fire risk has also been added to the organisational risk register, reflecting the proactive risk management. So real thorough piece of work. The paper outlines the key achievements over the last year, with significant improvements made around policy and processes, training and compliance monitoring, as Tim touched on in his highlight and exceptions report. The report and covering paper do detail the extent of our testing, and as a result, work that's taken place that is required to meet those requirements, and capital investment has been made that does rectify issues from the inspections or the audits as detail. And what I would say is also the restructure of the estates and facilities function with the arrival of our new director, but also as a result of support services redesign, has and will continue to improve the improvement needed in fire safety. But there is a level of grip and control shown throughout the report, as Tim has highlighted. Even where there are areas of concern, there are plans in place in order to address that. And that can really be seen by the audits of those external partners and contractors. And we have shown in the paper how we have addressed any of the concerns, even where the findings have actually deemed us as satisfactory. We have addressed some of the concerns raised, and as a result, and a big thank you to our Director of Estates and Facilities, who has really improved our working relationships with fire and rescue, and has been instrumental in taking this piece of work forward. So the People Committee felt assured by what was presented. So thank you, Kevin. This is just to ask for board to approve its publication again.
Thank you very much. It's comprehensive and detailed, and it's already been through People Committee for detailed assurance. So I'll pause a moment and allow colleagues that might have questions or comments to metaphorically put their hand up. If there aren't any, then can I ask that colleagues signal their approval for the report? That's great. Thank you very much. Thank you, Amy, and please pass on the board's thanks for the detailed work that's gone into producing the report. Thank you. We'll move on then to the final items on the agenda. The review of terms of reference, the target operating model and the Living Within Our Means programme board. Amy Poole, are you speaking to those in Karen's absence? Yeah, thanks, Amy.
Yeah, thank you, Kevin. Morning, Amy Poole, Deputy Trust Secretary. So this report provides the board with an opportunity to review the terms of reference for the Target Operating Model Programme Board and the Living With Our Means Programme Board. Prior to this meeting, both terms of reference have been considered by the respective programme boards and are recommended for approval. In both cases, the proposed amendments to the terms of reference are for meeting frequency to reduce from monthly to bi-monthly, with extraordinary meetings or virtual approvals being used if necessary. All the changes are largely administrative in nature. The terms of reference for the Appointment and Terms of Service Committee are also due for review. They'll be considered at the committee's meeting in October and be presented to the board for final approval at its meeting in December. In addition to the terms of reference, the report recommends some standardised wording to be added to all terms of reference regarding virtual approvals. These tend to be used for where decision items need a timely action in advance of a planned meeting or where it's not possible to arrange an extraordinary meeting. So in addition to approving those two terms of reference, the board is asked to approve the standard narrative that we've added for it to be retrospectively added to the terms of reference for the other board committees that were approved at last August meeting.
That's great, all very clear. Thank you very much. Amy, can I ask colleagues to indicate whether or not they're happy to approve those terms of reference amendments? Excellent, thank you very much. So the answer to that's yes. Are we sticking with you for the next item, Amy, which is the review of meeting timetables and the forward agenda?
Yes, thank you, Kevin. So this report presents the draft meeting timetable for 2026-27 and the forward agenda for the Board of Directors meetings, both of which are presented for approval. So last year, significant changes were made to the Trust governance structure and the associated meeting timetable. Throughout the year, the timetables proved to be effective, and therefore the next year's timetable mirrors the approach from last year. In June 2025, the board approved some time-limited proportionate governance arrangements in order to roll out the Living Within Our Means programme and maintaining good governance principles. As this programme is now well established, it's proposed that these proportionate governance arrangements come to an end in December. So the meeting timetable appended sees business as usual. Frequency of meetings return from January onwards. In relation to the Board of Directors forward agenda, there's no significant proposed amendments, and the timescales for reports being presented have been aligned to the relevant board committee forward agendas.
Again, that's all very clear. Thank you very much, Amy, for talking us through that. Are colleagues content with the proposed changes in meeting frequency and so on? Fabulous. Thank you very much, Amy, for that. And then we've got item 8.1, which is the forward board programme, which is just there for information, isn't it?
Yeah, that's right.
Great. That completes the formal agenda for the public section of our meeting today. I've got no items of any other business that have been notified to me, and there are none from the chair. So if there are no other items of business, we will conclude this public section of the meeting now, and I'm going to suggest that we reconvene for the private part of the board. It's now shortly before 20 to 11. Are colleagues content to reconvene at 10 to 11? If so, then that's what we will do. So see you again, those of us that will be rejoining the private meeting in about 10 minutes time. Thanks very much, everybody.
Thank you.
Thank you.